Bismillahirrahmanirrahim. On to the gastrointestinal anatomy. So firstly we'll talk about the retroperitoneal structures. The retroperitoneal structures are the ones which are situated behind the peritoneum, which are not covered by the peritoneum, or which are not encased by the peritoneum. That would be the right word to say. So retroperitoneal structures include the gastrointestinal structures that lack a mesentery and non-GI structures. So these are the GI structures and non-GI structures which don't have a okay. So these are the GI structures without a mesentery and other non-GI structures. They are included in the retroperitoneal structure. There is a list of them. We'll see them. Injuries to the retroperitoneal structure can cause the blood or gas accumulation in the retroperitoneal space. So now here you can see that this line, this whole thing, which I'm drawing a line over here. This thing is the peritoneum, and everything that is situated behind that is a retroperitoneal structure. Suppose there is an aorta, and if I say that the aorta gets ruptured because of any reason, if there is a laceration of aorta and blood starts accumulating over here, so there will be a retroperitoneal bleeding, that is bleeding behind the peritoneal cavity. And when there is bleeding behind the peritoneal cavity, so there will be increased pressure in the retroperitoneum. There is a whole constellation of symptoms that is associated with that. The only point that I want to highlight right now is that any kind of laceration or injury to the structures which are present in the retroperitoneal area will cause retroperitoneal bleeding. So what is the mnemonic to remember them? It is Sad-Pucker. Suprarenal gland. So Sad-Pucker is the mnemonic. S is for the suprarenal adrenal glands, which are not shown. Basically, suppose this is the kidney, and the glands which are located above the kidney. These suprarenal glands are retroperitoneal. Then aorta and inferior vena cava. Duodenum, second through fourth part. First part of the duodenum is intraperitoneal. Second, third, and fourth parts are retroperitoneal. The pancreas, except the tail. The tail is intraperitoneal. Ureters, which are not shown in the picture, but they are also retroperitoneal. The colon, descending and ascending colon. The kidneys, the esophagus, thoracic portion, which is not shown, and the rectum, partially not shown. Okay, so basically these are the structures which are retroperitoneal structures of high significance. There are other structures as well, but we are supposed to remember these things. So remember the mnemonic Sad-Pucker. S for suprarenal glands. A is for the aorta inferior vena cava. D is for the duodenum, second to fourth part. P is for the pancreas except the tail. U is for the ureter. C is for the colon, descending and ascending. The transverse colon is intraperitoneal. Then K is for the kidneys. E is for the esophagus, the thoracic portion, which is not shown. So actually the peritoneum is not present in the thorax, but if I draw it like that, like suppose this is the esophagus, and then here we have the stomach. So there is a small portion of esophagus that is below the diaphragm, and this is called the abdominal esophagus. And this abdominal esophagus is also situated behind the peritoneal cavity. It is retroperitoneal. And then we have the rectum, that is partially, some part of rectum is intraperitoneal, but the rest of it is retroperitoneal. Then we have this picture. In this picture you can see that there we have the ascending colon, that is retroperitoneal. The descending colon is retroperitoneal. Aorta, inferior vena cava, the kidneys, and here you have the liver. Liver is, I think liver is intraperitoneal. Yeah, liver is intraperitoneal. So these four structures, like ascending, descending colon, kidneys, and the aorta, inferior vena cava, these are retroperitoneal structures. I'm sorry for that. So there is an NPME point. The primary retropharyngeal organ has primary retropharyngeal blood supply. So there are some structures which are primarily retropharyngeal, like they were always retropharyngeal. They were never covered by they were never intraperitoneal, or they were never covered by some mesentery or something. Then there are secondary retroperitoneal, which were previously covered by the peritoneum, which previously had a mesentery, but they lost it during the embryonic development. So the primary retroperitoneal organs has the primary retroperitoneal blood supply, and the secondary retroperitoneal organ has a secondary retroperitoneal blood supply. Here you can see the major secondary retroperitoneal organs losing a mesentery during the development. The duodenum, second and third parts, head, neck, and the body of pancreas, ascending colon, descending colon, and upper rectum. So you can see all those organs which are partially intraperitoneal were actually intraperitoneal completely, but then some parts of them became secondarily retroperitoneal. As you know that the first part of duodenum is intraperitoneal, while the second, third, and fourth, these parts are retroperitoneal. So the second and third part is secondarily retroperitoneal. The first part is intraperitoneal, and the fourth part is primarily retroperitoneal. Okay. Again, duodenum during the embryonic life was completely intraperitoneal, right? The first part remained intraperitoneal even in the adult life. The second and third parts, they became secondarily retroperitoneal, while the fourth part of the duodenum, that was always retroperitoneal, right? Then pancreas was intraperitoneal, but as the development, as the development was going on, so the head, neck, and the body of the pancreas became retroperitoneal. Same is true for the colon. The ascending and descending colon becomes secondarily retroperitoneal, while the transverse colon remains intraperitoneal. And then upper rectum is secondarily retroperitoneal, while the lower rectum, that is intraperitoneal. And the major primary retroperitoneal organs never had a mesentery are the kidneys, adrenal glands, ureters, aorta, inferior vena cava, lower rectum, and the anal canal, right? So the lower rectum is not intraperitoneal, that is primary retroperitoneal. The upper rectum is secondarily retroperitoneal, while the lower rectum is primarily retroperitoneal. So remember these things. Actually, they don't ask you about these things like primary or secondary, but you must know the difference between them. Maybe there is some question in the step 1 exam, because now they're changing the question bank and stuff like that. So there is a captain point: during the ascending colectomy, the surgeon should take care of the ureter and the artery to the ascending colon, which is the left colic artery. Which of both of these are anterior to each other? The ascending colon is a secondary retroperitoneal structure, so its blood supply is also secondary retroperitoneal. The ureter is primarily primary retroperitoneal structure, so the ureter is behind the left colic artery according to the embryonic origin. So basically there is kind of a rule. The ureter is behind almost all the structures in the abdomen, except for the iliac arteries. It is moving over the iliac arteries, and for the rest of the structures it is below them. Actually, this is a very a very pathetic mnemonic, but I have made this mnemonic. We'll study this thing when we go to the renal section and or the reproductive section. We'll see that in detail over there. But remember that out of the left colic artery and the ureter is behind the left colic artery, because the ascending colon is secondary retroperitoneal structure, so its blood supply is also secondary retroperitoneal. The ureter is primarily retroperitoneal structure, so the ureter is behind the left colic artery according to the embryologic origin. Secondary retroperitoneal organ is always in front of the primary retroperitoneal organ. This is the rule, that all the secondary retroperitoneal organs will lie anterior to the primary retroperitoneal organ. So you can see in this analogy as well, like the duodenum, the pancreas, the colons, they are anterior to the kidneys and the ureters and the aorta and stuff like that. So even in this picture you can see that the ascending colon, descending colon, they are lying anterior to the aorta and kidneys, because the aorta, inferior vena cava, the kidneys, they are primary retroperitoneal structures, while the ascending and descending colons, they are secondary retroperitoneal structures. So this is the arrangement of the structures inside the abdomen, which they have tried to depict in this picture and in the discussion. The Uworld point, there is a case that there was an accident and there was retroperitoneal hematoma and hemodynamically stable patient. So what is the structure that has been damaged? It is pancreatic trauma, as it may cause mild to asymptomatic bleeding. Note, NBME point is injury to the transverse colon or spleen or liver, hemoperitoneum, not the retroperitoneal hematoma. Remember that whenever they give you a question statement, they say that there was a person who had blunt trauma to the abdomen and there is some sort of internal bleeding going on. Most of the time they want to take you towards spleen, because spleen is a very fragile structure. But if they are mentioning specifically that there is retroperitoneal hematoma, so this excludes the spleen, because spleen is intraperitoneal, right? Spleen is present inside the peritoneum. So if the spleen has been damaged, so resultantly the bleeding will be intraperitoneal and there will be hemoperitoneum. And if they are saying that there is retroperitoneal bleeding, so most probably it is coming from the pancreas, because that is retroperitoneal in its orientation. The NBME point is injury to the transverse colon or spleen or maybe liver, there will be hemoperitoneum, not the retroperitoneal hematoma. Uworld point about the duodenum is that the first part of the duodenum is at the level of L1. The only part of the duodenum that is not retroperitoneal, right? This is always intraperitoneal. The L1 is, the first part is at the level of L1. So suppose there is vertebra L1, then we have L2, and then we have L3. So the duodenum moves something like that. Like it is, the L1 is moving like this over the L1. Then the second part is the descending part. So it moves parallel to the L1 to L3. Then the third part moves over L3, and then the fourth part is ascending upwards. Maybe L to the level of L2 to L3, and then it fuses with the jejunum and stuff like that. So they are saying that the first part is at the level of L1, and this is the part that is not retroperitoneal, the only part. The second part of the duodenum courses inferiorly from the level of L1 to L3, like it is moving from the L1 to L3 downwards, in close relationship to the head of pancreas, and consists of ampulla of Vater, the site where the pancreas and the common bile duct secretions are released. We have talked about that now quite a few times, but let's talk about this once again. Suppose this is the duodenum I am drawing right now. Can I remove this? I don't think so. Okay. So suppose that this is the duodenum. Let's go here. Yep. Suppose this is the duodenum that I am drawing. It is a C-shaped organ, like it is the part 1 that is at the level of L1, then the second part that is moving downward from the L1 to L3. So in the second part, we have the pancreatico-duodenal fistula, not the fistula. I'm sorry. It is the common bile duct and the pancreas. So pancreatico-duodenal ampulla of Vater is present over here. So pancreatico, I don't know, I don't remember the name of that. I guess it is hepatopancreatic duct. Yeah, it is hepatopancreatic duct because the common bile duct is coming from the liver, and this duct is coming from the pancreas. So it is called as hepatopancreatic duct, and they open in the major papilla. And this is the point of demarcation of the foregut. Like foregut is above it, and midgut is below that. So this is the point, and this area is called as the ampulla of Vater, and there is a sphincter that is called as sphincter of Odi. Now let's come back. So the third part of the duodenum courses horizontally over the L3, the abdominal aorta and the inferior vena cava. So it is coursing horizontally, like this is the third part. It is coursing horizontally over the level of L3, the abdominal aorta and the inferior vena cava. It is in close association with the uncinate process of the pancreas and superior mesenteric artery and vein. It is very important to be remembered because there are some structure, like you can see that this is the third part, and third part is in close association with the superior mesenteric artery that is descending over that. You can see the superior mesenteric artery, and they have not shown the vein, but also the vein, artery and vein, superior mesenteric artery and superior mesenteric vein, they are descending over the third part, and it is of very high clinical significance. We'll see that later on, but for right now, remember this anatomy. That it courses horizontally, and then it is in close association with the uncinate process. So there is an uncinate process, like there will be the uncinate process that is lying posterior to the duodenum, and superior mesenteric artery is lying anterior to the duodenum. And superior mesenteric artery and vein, the small bowel malignancies are rare. It is very important point that in Pathoma, Dr. Abdul Sattar was saying that we always talk about the tumors of the oral cavity, maybe esophagus, maybe stomach, and then we skip the small intestine and directly go to the tumors of the colon, because the tumors of the small intestine are very rare. Like remember that the small intestinal malignancies are a very rare finding. If they occur in the third part of the duodenum, anterior tumor invasion could compromise the superior mesenteric vessels. So normally the tumors don't develop here, right? They are very rare. But if they develop here, so they will move anteriorly, and then they will compromise the blood supply of the superior mesenteric artery, and superior mesenteric artery is the main blood supply of the midgut. So if superior mesenteric artery is blocked because of some tumorous mass, the blood supply to the whole of the midgut will be compromised, and there will be severe necrosis and necrotizing enterocolitis may be seen in the children, or maybe in the adults we see severe abdominal pain and stuff like that. So mesenteric ischemia, that is called mesenteric ischemia. We'll see that in detail, but for right now remember that any tumor in this region can compromise the blood supply in the superior mesenteric artery. The fourth part of the duodenum courses superiorly and to the left of the L2 and L3 vertebra and becomes jejunum past the ligament of Treats. So suppose that it is the jejunum down here, and there is the fourth part. This flexure, this sharp demarcation between the fourth part and the jejunum, there is a ligament that is called ligament of Treats, and this is demarcating the end of the duodenum and the beginning of jejunum. Then we have these structures like that. So there are right superior mesenteric artery syndrome. We have to see that because this is the third part of the duodenum, and superior mesenteric artery is coursing anterior to that. Now let's zoom this structure first. So here you can see that there are a lot of structures, and the superior mesenteric artery is coursing anterior to the duodenum, and in this picture you can see it is also compressing the third part of the duodenum to some extent. This is duodenum, and then we have the left renal vein that is traversing behind that and stuff like that. So in the cut section of this region, when it is depicted over here, so you can see that in a normal person, the superior mesenteric artery is traversing over the third part of duodenum, and between the superior mesenteric artery and the abdominal aorta, we have duodenum, the left renal vein, and the yellow thing that is present between them is the fat pad. The fat pad protects the duodenum and the left renal vein from being compressed by the superior mesenteric artery. But in the people who are maybe having very low amount of fat in the body overall, or maybe the anorexic women or the malnourished children or something like that, they can have the diminishing of this fat pad between these two structures, and resultantly the superior mesenteric artery starts compressing the third part of duodenum and the left renal vein, and we get something like this. we get an abnormality, something like this. This is called the duodenal compression. So here you can see the aorta, superior mesenteric artery, then the left renal vein that is being compressed, the duodenum's third part being compressed, and the fat part that is being almost completely vanished in this picture. Here you can see the superior mesenteric artery syndrome. It is characterized by the intermittent intestinal obstruction symptoms, primarily post-prandial pain. Okay, when transverse third portion of the duodenum is compressed between the superior mesenteric artery and the aorta. It typically occurs in the conditions associated with the diminished mesenteric fat, for example, the low body weight, malnutrition, and stuff like that. Then we have next structure. The anatomy of pancreas is of very high significance. The pancreas contains head, neck, body, and a tail as well. Okay, so the head, neck, I'm sorry. The head, neck, and body of the pancreas are retroperitoneal, whereas the tail is intraperitoneal or peritoneal structure. The head of the pancreas lies in the curve of the duodenum. Like suppose this is the duodenum, the C-shaped duodenum. The curve of the pancreas, the head of the pancreas is lying over here, like in the, the pancreas is a structure like this. So the head of the pancreas is lying in the C of the duodenum. In the curve of the duodenum, and over lies the L2 vertebra with a portion extending behind the superior mesenteric vessels uncinate process. So the uncinate process is moving behind the mesenteric vessels. The neck lies anterior to the portal vein and superior mesenteric vessels. So I guess there is a picture. The portal vein and what? The portal vein and the superior mesenteric vessels. The neck lies anterior to the portal vein and superior mesenteric vessels. The neck is lying, okay, so here you can see that this is the neck, and neck is lying anterior to the portal vein as well as the superior mesenteric vessel. So it is the neck of the pancreas behind which the portal vein is formed. What is the meaning of that? The portal vein is formed by the confluence of the splenic vein, the inferior mesenteric vein, the splenic vein coming from the spleen. Suppose there is a spleen, there is a splenic vein, then we have the inferior mesenteric vein, and then there is superior mesenteric vein. All these three veins join together just behind the neck of pancreas to make the portal vein, and then portal vein will enter the liver, right? So this is the neck of the pancreas that is lying anterior to the superior mesenteric artery as well as the portal vein. Then we have the body that makes the contact posteriorly with the aorta, left adrenal gland, left kidney, and the renal vessels. The tail courses within the splenorenal ligament alongside the splenic vessels. So splenorenal ligament is basically a, you may say a ligament or a connective tissue membrane that is connecting the tail courses. That is basically a connection between the spleen and the kidneys, you may say that is called splenorenal ligament, and this harbors the tail of pancreas alongside the splenic vessels like the splenic artery and the splenic veins and stuff like that. So this is the picture. You can see a lot of different structures. Let me zoom it in. I will try to explain as much as I could. So here you can see, firstly we'll start from here and then we'll go in the counterclockwise direction. So this is inferior vena cava that is present behind the pancreas, the hepatic artery, the common bile duct, and the right adrenal gland. So here you can see the hepatic artery. Let me change the color of that. So this is hepatic artery. This thing is bile duct, and this particular blue structure is the hepatic portal vein. So these three things together are called as the portal triad. Then we have the right adrenal gland, like this yellow thing is right adrenal gland. Then we have the kidney. Then this is duodenum. Head of the pancreas is like this, and then the uncinate process is the projection of the pancreas downwards. Then behind the neck of the pancreas we have inferior vena cava, superior mesenteric artery, and the portal vein. Then this, okay, so this is portal vein. This is not inferior vena cava. This is portal vein. Then here we have the aorta, the kidney, the tail of the pancreas, the spleen, the splenic artery, the left adrenal gland, and stuff like that. Now I guess these are the pictures from the 100 points. I will try to upload the 100 points as soon as possible. So 100 anatomy points basically. So here you can see the neck of the pancreas. So this is the liver, and like 1, 2, 3. So they're trying to say the posterior to the neck of the pancreas is the site of formation of the portal vein. The splenic vein joins with the superior mesenteric vein to form the portal vein. So the splenic vein, now you can see it better, that the splenic vein coming from this direction joins with the inferior mesenteric vein, and both of them join with the superior mesenteric vein. Where is superior mesenteric vein? This is the superior mesenteric, just give me a second. So this is the superior mesenteric vein. This joins with them to form this portal vein which is going upwards. So splenic vein, inferior and superior mesenteric veins join to form the hepatic portal vein. This formation is happening behind the neck of the pancreas. So there they have shown that the splenic vein joins with the superior mesenteric vein to form the portal vein. Now in this picture they have shown that the body passes to the left and pass anterior to the aorta and to the left kidney. So this red structure, now you can see that this is the body of the pancreas. So this body of the pancreas is passing anterior to the aorta and the kidney to pass to the to ultimately approach the spleen to the left side. So the body passes to the left and passes anterior to the aorta and left kidney. The splenic artery undulates along the superior border of the pancreas, superior border of the body of pancreas, and the splenic vein coursing posterior to the body. So now here you can see that the splenic artery is undulating on the superior margin of the pancreas or the superior margin of the body of pancreas, and then what happens to that? Pancreas with the splenic vein coursing posterior to the body. The splenic vein is coursing posterior to the body, while the splenic artery is undulating on the superior border of the body. This is very high, hardcore anatomy which you are not supposed to remember, but just for the completion's sake, I'm reading these points. The tail of pancreas enters the splenorenal ligament to reach the hilum of the spleen. It is the only part of the pancreas that is intraperitoneal. The rest of the structures of the pancreas are secondarily retroperitoneal. So just give me a second. Actually, there was a mess up. I guess we were here, almost here. Okay. Then the tail of the pancreas may be mistakenly removed during the splenectomy. There are a lot of situations when we have to do the splenectomy. For example, for the sickle cell patients, when the spleen has been fibrosed, or during maybe some cases when the spleen has, whenever there is too much splenomegaly, that the platelets have become engorged inside the spleen and there is functional thrombocytopenia. So in all those scenarios, we have to do the splenectomy, and during splenectomy, we may accidentally remove the tail of the pancreas. And that results in the sugar diabetes because it contains a lot of endocrine cells. So the tail of the pancreas contains a lot of endocrine cells, like a lot of beta islet cells and a lot of alpha cells, and when those endocrine cells are removed, so the person may develop diabetes mellitus. Okay, then we have the lesser omentum. The lesser omentum is a double layer of peritoneum that extends from the liver to the lesser curvature of the stomach and the beginning of the duodenum. So they have shown a picture of that. Let me zoom it in. So now you can see that the lesser omentum is this structure, this yellow line, this thing. It is the lesser omentum that is extending from the liver above, that it is extending from here on the liver and downward on the lesser curvature of the stomach. This is the lesser curvature of the stomach and also over the duodenum. So this is the area that is being covered by the lesser curvature. Not lesser curvature, this is the area that is covered by the lesser omentum. So now here you can see that it is a double layer of peritoneum that extends from the liver to the lesser curvature of the stomach and the beginning of duodenum. Anatomically, the lesser omentum is divided into two ligaments. The hepatogastric ligament, it has two parts like hepato and gastric. The hepatogastric is going from the liver to the stomach. The portion connecting the lesser curvature of the stomach, the portion connecting to the lesser curvature of the stomach. So here you can see in the picture that this translucent area as depicted in the picture. So this area joining the liver to the lesser curvature of the stomach all the way till here, this is the hepatogastric ligament, while the area that is joining the liver to the upper portion of the duodenum, upper margin of the duodenum, this thing is called as the hepatoduodenal ligament. We'll see that now. So here you can see now that the first thing was hepatogastric ligament, the portion connecting to the lesser curvature of the stomach. Then we have the hepatoduodenal ligament, which is the portion connecting to the duodenum. Between the two layers of the lesser omentum, close to the right side free margin, the hepatic artery, common bile duct and the portal vein, lymphatics and hepatic plexus, close to the right side free margin, lie the hepatic artery, common bile duct and the portal vein, lymphatics and the hepatic plexus. The right and left gastric arteries and the veins also lie between the two layers, near where the lesser omentum attaches to the stomach. So firstly, let's talk about the portal triad that contains hepatic artery, common bile duct and the portal vein. They are present in this free margin. There will be a picture later on. So you know that, just give me a second. So here you can see that there is a free margin over here, like this free margin, this free margin. This free margin from where we have an opening that is called as the epiploic foramen, epiploic or the mental foramen, through which we can enter to the lesser sac. So this free margin that contains the portal triad, and that portal triad contains the hepatic artery, the bile duct and the portal vein, right, along with the lymphatics and the hepatic plexus of nerves. And then the right and left gastric arteries and the gastric vein also lie in the two layers, near where the lesser omentum attaches to the stomach. So we know that the left gastric artery is passing over here. The left gastric artery is moving in this direction on the lesser curvature, and the left gastric vein is also present parallel to that. So these structures are enveloped also, they are also enveloped by the lesser sag or the lesser momentum, but on the lesser curvature of the stomach, right? So you must remember the structure in the free margin as well as on the lesser curvature of the stomach. Then we have okay, so let's read this diagram. We'll move in the anti-clockwise direction, like this, lesser, okay, in that direction. So there we have the falciform ligament, then we have the round ligament of the liver. After that we have the quadrate lobe, like this is the quadrate lobe, this thing over here. Then we have the gallbladder, the green structure, the right lobe of the liver is present over here, the omental foramen, then the pylorus, the right kidney, the duodenum, the right colic hepatic flexure. Then over here you can see the lesser omentum, which contains the hepatoduodenal ligament, and then the hepatogastric ligament. Then there is left lobe of the liver, stomach, and the spleen is present like that. The left colic or the splenic flexure. The left colic splenic flexure is basically, the spleen is present over here. So the transverse colon, the junction of the transverse colon to the descending colon just below the spleen is called as the splenic flexure. It is also called as the Griffith point, and that is the watershed area. We'll read about that in the general pathology inshallah soon. And then we have the greater omentum. In the next picture you can see the epiploic foramen. So the epiploic foramen, it has boundaries like anterior, the posterior, superior, and inferior. Basically it is the foramen through which we can enter into the lesser sac, and that is, the lesser sac is situated behind or posterior to the stomach, you may say that in easy words. Anteriorly, the free border of the hepatoduodenal ligament containing the portal triad. So here you can see that this is the hepatoduodenal ligament from the liver to the upper part of the duodenum, and that contains the portal triad, and this is forming the anterior boundary of this epiploic foramen. If I could zoom it in, so now you can see that this is the epiploic foramen. So the anterior boundary is being formed by this thing, by the hepatoduodenal ligament. Yep. Then posteriorly we have inferior vena cava, as you can see in this picture. You can't see in this picture, but inferior vena cava is located like posteriorly. Then we have superiorly the caudate lobe of the liver. This caudate lobe, like this is the caudate or lobe of the liver that is present superior to the epiploic foramen, and inferiorly we have the first part of the duodenum. So the anterior and the inferior relationships are very clear, because this anterior structure is the portal triad, right? Inferiorly we have the upper part of the duodenum, then posteriorly we have inferior vena cava, and superiorly we have the caudate lobe. That's it. Moving forward to the next point, that is about the portal triad. There is a Uworld point about that. So runs through the hepatoduodenal ligament, composed of the hepatic artery, the portal vein, and the common bile duct. In the setting of traumatic liver injury with persistent bleeding, occlusion of the hepatoduodenal ligament can be performed to identify the vascular source. It is called as the Pringle maneuver. So about the Pringle maneuver, you must remember that if the liver bleeding does not cease when the portal triad is occluded, it is likely that there has been injury to the inferior vena cava or hepatic veins. So suppose that you were performing some sort of surgery, or maybe not even in the surgery, there was some sort of traumatic injury to the abdomen, and there was frank bleeding inside the abdomen. Now in that particular case, you don't know from where the blood is coming. What do? You clamp the hepatoduodenal ligament. We know that in the hepatoduodenal ligament we have the portal triad, and the portal triad contains hepatic artery, the vein, and the bile duct, right? After clamping that, if the bleeding stops, so we know that the site of origin of the bleeding is either the hepatic artery or maybe the hepatic vein. But if the bleeding does not stop, so we know that the site of origin is something other than this area. Like this rules out the portal triad to be the bleeding source. Now the bleeding source is either the inferior vena cava or the aorta. So this is the Pringle maneuver. Then we have the greater omentum. The large fold of the visceral peritoneum that extends from the greater curvature of the stomach travels inferiorly over the small intestine and then reflects on itself and ascends to encompass the transverse colon before reaching the posterior abdominal wall. So there are a lot of pathetic diagrams in the not in the net. There are a lot of diagrams which you see in the schematic diagrams, like they draw structure like this and covering like this. So that is always confusing. So I will not draw structures like that. So I will request you to either to see the netter at least, or maybe you should go to some other structure or maybe some animation, because they're good enough. But the point is, let's suppose this is the stomach, like this is the stomach. It has two curvatures. This is the lesser curvature and this is the greater curvature. So on the lesser curvature of the stomach, we have the attachment of what? Of the lesser sac, right? The lesser sac is coming and attaching on the lesser curvature. The greater sac is coming and attached to the greater curvature. So this is as simple as that. Like to the lesser curvature, we have the attachment of lesser omentum, and to the greater curvature, we have the attachment of the greater omentum. If we are clear on that, so I will move to the next point. So on the next point, from the greater curvature of the stomach, the greater omentum moves downwards all the way like a hanging towel or a hanging apron over the intestines. It is not covering the intestine, it is just moving downwards, and then it reflects back as a second layer like this, like it is reflecting back. I hope I could draw a three-dimensional picture. So it is reflecting upwards, and then it encompasses the transverse colon which is present over here. So it contains the transverse colon inside it, and in this way it is making a ligament that is called as the gastrocolic ligament. The gastrocolic ligament is depicted over here, I guess. Transverse mesocolon, where is gastrocolic ligament? I don't think they have mentioned that. But the gastrocolic ligament is the ligament or the part of the greater omentum that is present between the greater curvature of the stomach and the transverse colon. But you are supposed to watch some sort of animation or stuff like that, because it is very important concept to be remembered as per anatomy of the GIT is concerned. It is found by the two ligaments, that is gastrocolic ligament and the gastrosplenic ligaments. The gastrocolic ligament in the section that stretches the greater curvature, of the stomach to the transverse colon. So basically it is the connection between the greater curvature and the transverse colon, that is called the gastrocolic ligament. In this, it forms a part of the anterior wall of the lesser sac. It is divided during the surgery to provide access to the anterior pancreas and the posterior wall of the stomach. So it is providing the anterior wall to the lesser sac, okay, and it is divided during the surgery to provide the access to the anterior pancreas and the posterior wall of the stomach. So here you can see that if there, this is the greater curvature of the stomach, right? This is the greater curvature, and they are saying that the greater omentum is cut. So the connection between the transverse colon and the greater curvature of the stomach, this thing is called the gastrocolic ligament. We have cut that open to approach the posterior part of the stomach. Like you can see the posterior part of the stomach, we have lifted it upwards after making a pocket, or after cutting the greater omentum, after cutting the gastrocolic ligament specifically, and also we have reached the anterior surface of the pancreas, which is lying over here, and we have also reached the anterior, we have also reached the lesser sac, because lesser sac, the epiploic foramen was going to the lesser sac, and by cutting the transverse colon, by cutting the gastrocolic ligament, we have also entered the lesser sac. Please watch some sort of animation for that. I am reiterating that over and over again because it is very important concept, and it is very hard for me to explain that in the very confined time bracket, and also with this two-dimensional view. I can't explain that right now, but please watch some sort of animation, because it is a very easy concept, and because of no reason, because of some difficult terminology, greater omentum and lesser omentum, it feels difficult. It is not difficult at all. So definitely you will get a thorough understanding by watching some good animations. Then we have a Uworld point, that is to access the anterior pancreas and posterior wall of the stomach, divide the gastrocolic ligament to reach the lesser sac, as it forms the anterior wall of the lesser sac. Another Uworld point is that in order to encircle the stomach, the band must pass through the lesser omentum. Okay, adjustable gastric banding of the obesity. So basically we are trying to do, there is a surgery in which we apply a band to the stomach, in which we do something with the stomach. I guess we are cutting the stomach, or maybe applying a band to that. So for that band to encircle the stomach, it must pass through the lesser omentum. Adjustable gastric banding for the obesity placed around the gastric cardia, and decreased passage of the food. So basically, suppose this is the stomach, and this portion is called as the cardia, and this portion is called as the cardia, and we apply a band around that in the gastric banding, so that the entry of the food is limited and the person cannot ingest much food. So that helps us cure the obesity. Then we have the beginning of the duodenum, the lesser omentum, double layer of the peritoneum. Lesser omentum is a double layer of peritoneum from the liver to the lesser curvature of the stomach, and the beginning of duodenum. Between the two layers, free margin, hepatic artery and the common bile duct and the portal vein is present, that is also called as the portal triad. This is the lesser sac. So in this lesser sac, you can see, we'll read the picture again in the counterclockwise direction. This is the stomach as lifted upwards after cutting the gastrocolic ligament. This is the greater omentum, the cut section of that. Epiploic foramen is present just below the liver, from which we can enter the lesser sac. Then we have it is from the Natter page number 264. It is 264th slide of the Natter atlas. Then we have the pancreas, the anterior portion of the pancreas like that. Then the transverse mesocolon is present. This is the transverse mesocolon, which is supplying the blood supply to the transverse colon. Then we have the greater omentum, like this thing, the apron-like structure, present below that. Then splenorenal ligament is present over here. This is the splenorenal ligament. I guess now it is more clear. This is the splenorenal ligament over here. Then we have Another thing that is called as splenorenal ligament, that is like this. The gastrosplenic ligament that has been cut, and the gastrophrenic ligament is connecting the stomach with the pancreas, with the diaphragm. Then we have this diagram. Okay, let me zoom it in so that we could see the important gastrointestinal ligaments. There are a lot of ligaments. We have depicted the important ones in this diagram of the first state. So the falciform ligament is connecting the liver to the anterior wall of the stomach. The anterior abdominal wall is connected to the liver by the falciform ligament. Then we have the proper hepatic artery, the common bile duct, and the portal vein, all of them present inside the hepatoduodenal ligament. The portal triad within the hepatoduodenal ligament. Then this thing is called as the liver. Then actually it is a cut section, and if you feel like it, so you may also call it a CT cut section, because on the CT scan you get a picture like this. Not so clear, there are vague structures, vague opacities and vague illuminations, but it is a cut section of the human body at the level of abdomen. Then we have this thing is liver. Then omental foramen, epiploic foramen of Winslow. Okay, so there we have the epiploic foramen. So epiploic foramen is present over here, that leads to this lesser sac. This whole brownish structure is the lesser sac, and the epiploic foramen is leading us to this lesser sac. Then the greater sac is present like this over here. Then we have the right kidney, the left kidney, the inferior vena cava, that is a retroperitoneal structure, and this is the T12 vertebra. Then the aorta, that is also a retroperitoneal structure. The lesser sac is depicted in this picture like that. The left kidney is over here. So this is the right side of the body, the left side of the body. The left adrenal gland over here. The splenorenal ligament. Okay, this is a beautiful thing. So here you can see the splenorenal ligament. This is basically the spleen, and splenorenal ligament is containing the this is the splenorenal ligament that is connecting this kidney and to the spleen. The ligament between the left kidney and the left spleen is called as the splenorenal ligament. Then we have the visceral peritoneum, the gastrosplenic ligament. So there are two ligaments attached to the spleen. The first one is the gastrosplenic ligament attaching the stomach, the gastrosplenic, and the splenorenal ligament. So spleen is in close proximity to the stomach and to the kidney, right? So between the stomach and spleen we have the gastrosplenic ligament, and between the spleen and kidney we have the splenorenal ligament. This is the spleen, then we have the stomach, then the gastric vessels are looking like this, then gastrohepatic ligament within the lesser omentum, they are present over here. So gastrohepatic ligament is present within the lesser sac. We have seen the picture of that, like this thing is a gastrohepatic ligament, like this structure. This is the gastrohepatic ligament. Moving forward to this point over here, now let's see the description of all of these ligaments one by one. The falciform ligament, it connects the liver to the anterior abdominal wall. Structures which are present in that are the ligamentum teres hepatis. It is the derivative of the fetal umbilical vein. It is a remnant of the fetal umbilical vein that is going to form the ligamentum teres hepatis, and the ligamentum teres is present in the falciform ligament. Notes derivative of the ventral mesentery. So suppose this is the gut tube. So initially it is attached on to the anterior abdominal wall by the ventral mesentery, and to the posterior abdominal wall by the posterior mesentery, right? So the falciform ligament is a derivative of the ventral mesentery. Then we have hepatoduodenal ligament. The hepatoduodenal ligament is like it connects the liver to the duodenum. It contains the portal triad, proper hepatic artery, the portal vein, and the common bile duct. Note the Pringle maneuver. Ligament may be compressed between the thumb and the index finger, placed in the omentum foramen to control the bleeding. Borders the omental foramen, which connects the greater and lesser sac. The gastrohepatic ligament, liver to the lesser curvature of stomach. The gastrohepatic ligament attaches the liver to the lesser curvature of stomach. It contains the gastric arteries, the left gastric artery, maybe the the esophageal arteries, something like that. So we'll see them later on, but it contains the gastric arteries. It separates the greater and lesser sac on the right, and may be cut during the surgery to access the lesser sac. The gastrocolic ligament, which is not shown in the picture, it is a junction between the greater curvature and the transverse colon. It contains the gastroepiploic arteries. So on the lesser curvature, suppose this is the stomach. I draw stomach again and again. Like suppose this is the stomach. On the lesser curvature of the stomach, on the lesser curvature, just give me a second. Yeah, I don't have a curvature now. So there's the esophagus, and then we have a curvature like this. So on the lesser curvature of the stomach, we have left gastric artery and left and right gastric artery basically. So we have the left gastric artery from coming in that direction, and the right gastric artery, then anastomose on the lesser curvature. while the left and right gastroepiploic arteries, they are anastomosing on the greater curvature of the stomach. We'll see that blood supply later on, but for right now, just remember this thing. Then we have the next point, that is about the gastrocholic ligament. We're done with that. So gastroepiploic arteries are present over here. It is a part of the greater omentum. The gastrosplenic ligament, greater curvature of the spleen. So it is greater curvature and spleen. So the gastrosplenic ligament, as the name indicated, is the ligament between, it is the joining of the stomach to the spleen. So it attaches the greater curvature to the spleen. Short gastric arteries, the left gastroepiploic vessels are present in that. It separates the greater and lesser sac on the left and part of the greater omentum. The splenorenal ligament, spleen to the posterior abdominal wall. The splenic artery and vein and the tail of pancreas are contained in the splenorenal ligaments. Splenic artery, splenic vein and the tail of pancreas are present inside the splenorenal ligament. Then what is digestive tract anatomy? Layer of the gut wall inside the MSMS. So basically the digestive tract anatomy, you may say histology. So this MSMS is the basic framework of the GIT from the oral cavity down to the anal canal. Like it is the same throughout. Firstly, the innermost structure is the mucosa that contains epithelium, lamina propria and muscularis mucosa. These three structures combined are called as a mucosa, that is epithelium of whatever kind. Like for example, if I'm talking about the esophagus, it is stratified squamous. If I'm talking about intestine or stomach, maybe so it is columnar epithelium, simple columnar epithelium. So there is a difference in the epithelia, but mucosa of all the GIT is made up of three components. First thing is epithelium, second thing is lamina propria, and the third thing is going to be the muscularis. The submucosa, it includes the submucosal nerve plexus, which is also called as the Meissner nerve plexus. It secretes the fluid. So if I could show you in this picture, like it is a good picture, here they have shown that this is the mucosal layer. So mucosal layer is constituted, is being formed by the mucosa. Mucosa contains okay, so they have not shown lamina propria, but they have shown muscularis propria, muscularis mucosa. Muscularis mucosa is a very fine layer of muscles which is present inside the mucosa. So suppose this is the epithelial layer, then we have the lamina propria, and then we have the muscularis. So all these three layers combined, they are called as the mucosal layer. Just between, and then we have the submucosa, like this pale area is submucosa, right? So this pale area is submucosa. Between the mucosa and submucosa, we have a nerve plexus, and that nerve plexus is called as the Meissner nerve plexus, since it is present just below the mucosa. So what is the function of mucosa? Mucosa is, the part of the GIT that is responsible for secretion of a lot of things, like mucosa, like the mucus will be secreted from the mucosa, the HCl will be secreted from the parietal cells which are a part of the mucosa and stuff like that. So these are the things, like the mucosa is responsible for secretions. So the nerve plexus that is present just below the mucosa is also helping in the secretions. So the submucosa secretes the fluid. Then we have so basically it is the most of the glands are present in the submucosa. The mucosa is only the channel through which the fluid is entering the lumen of the organ. Then the muscularis externa, it includes the myenteric nerve plexus, auribac nerve plexus, and that is responsible for the motility. So then we have the muscularis externa, like this red structure. This is the muscularis. So basically mucosa, submucosa, then muscularis propria or muscularis externa. So that contains two layers: oblique layer of the smooth muscles, then circular of smooth muscles, and the longitudinal. So between the longitudinal, okay, let me zoom it in. Between the, here you can see, between the longitudinal smooth muscle layer and the circular smooth muscle layer, we have this thing that is called as the myenteric plexus or the auribac plexus. This plexus is responsible for the motility, and this plexus is lost in achalasia as well as in the Hirschsprung disease. We'll see that later on. But for right now, just remember that the muscularis externa includes the myenteric nerve plexus, and it is responsible for motility. Serosa when intraperitoneal, and adventitia when retroperitoneal. So all the structures which are intraperitoneal, like spleen, like first part of the duodenum, the outermost covering is called as serosa. And for all the structures which are retroperitoneal, like the ascending and the descending colon, the outermost structure is called as adventitia. Ulcers can extend into the submucosa, inner and outer muscular layer. Erosions are in the mucosa only. That is very important terminology. Like you must be able to differentiate between the erosion and the ulcer. Erosion is just the mucosal tear. Like suppose the mucosa is damaged, only the mucosa, this thing, this dark purplish layer, if that is damaged, that is an erosion. If the damage or if the laceration is extending beyond that into the submucosal layer, that is called as an ulcer. It can extend into submucosa, inner and outer muscular layer. If the lesion has extended beyond the mucosa and it started involving submucosa, maybe the inner and outer muscular layer and all that, then it is called as an ulcer. But before that, if the mucosa is, only mucosa is involved, that is called as erosion. Frequencies of the basal electric rhythm. Stomach is 3 waves per minute, duodenum is 12 waves per minute, and ileum is 8 to 9 waves per minute. These are the slow wave potentials which are generated within the stomach. So stomach has, like just like the heart, stomach has also a pacemaker activity inside itself. So although the vagus nerve supplies the GIT and vagus nerve exists in the peristalsis, but the peristaltic activity is independent of the vagus nerve. It is generated inside the GIT by this myenteric and the mesenteric plexus, basically the myenteric plexus. And every organ, every part of the GIT has its own pacemaker frequency. Like for the stomach it is 3 waves per minute, for the duodenum it is something 12 waves per minute, and the ileum it is 8 to 9 waves per minute. Then the digestive tract histology. Esophagus it is lined by the non-keratinized stratified squamous epithelium. The stomach it is lined by the gastric glands. The duodenum contains villi and microvilli. The villi are visible on the light microscope while the microvilli are visible on the electron microscopy, and these are responsible for increasing the absorptive surface. The Brunner gland is also a very specific thing that is associated with the duodenum. Whenever they will be trying to tell you of some pathology of the duodenum, they will tell you that there is Brunner gland hyperplasia or something like that. So Brunner gland is present in the duodenum. Bicarbonate secreting cells of the submucosa and the crypts of Leiber-Cohen are also present in the duodenum. In the jejunum, we have plica circularis and the crypts of Leiber-Cohen. In the ileum, we have Peyer's patches. It is very important. Like the Peyer's patches are kind of specific for the ileum, and the Brunner gland is specific for the duodenum. So the Peyer's patches lymphoid aggregates in the lamina propria and submucosa. Plica circularis is also present proximal ileum. Okay, so plica circularis is present only in the proximal ileum. Then we have crypts of Leiber-Cohen. Like crypts of Leiber-Cohen are present like in the duodenum as well as jejunum and ileum. So these crypts are present throughout the small intestine. In the colon, okay, from the duodenum all the way down to the rectum, the crypts of Leiber-Cohen are present, but they don't contain villi, and abundant goblet cells are present in the colon. After that, we have this thing that is a picture. So in this picture, you can see the small intestine. Small intestine contains the blood vessels serving the small intestine. The lumen is over there. There are circular folds which are called as plica circularis. They are present in the jejunum as well as in the duodenum. Not in the duodenum. Yeah, they are not present in the duodenum. They are present in the jejunum and ileum. So these are plica circularis, and then we have the muscle layer. The villi are present like that. This is a picture of duodenum in which you can see villi. These are the Brunner glands. Then we have crypts. So Brunner glands are responsible for the production of bicarbonate. Remember, because the duodenum is the first place from which the acidic chyme from the stomach will approach. Like it is the first part of the intestine where the acidic chyme which is coming from the stomach is approaching. So it needs to alkalinize that or neutralize that acidity, and it does that by the Brunner gland bicarbonate secretion. Then we have muscularis mucosa, the inner circular layer and outer longitudinal muscle layer. Here you can see that this is a picture of stomach. So in the stomach we have a simple columnar epithelium that is lining the stomach. Then we have the upper glandular layer. The deeper aspect of the gastric glands are present, like this is the upper glandular layer, then the deeper aspect of the glandular layer is present over there. Then muscularis mucosa is there, then submucosa. So nobody is going to ask you about this, this much histology, but just for the sake of completion, why not? This is the small ileum maybe, because there are Peyer's patches. So these patches, like these are the Peyer's patches. Actually, the lymph nodes are aggregated below the intestines, right? Below the mucosa, in the maybe lamina propria, you may say that. No, it is, no, not lamina propria, it is in the submucosa. So the lymphoid aggregates, the lymphatic cells, they start approaching the submucosa of the glands. If they become aggregated, those aggregates of the lymphoid tissue are called as the Peyer's patches. Sometimes these Peyer's patches contains a layer of cell over them that is called as the M cells. We'll see them in the microbiology in detail, inshallah. So for right now, just remember these are the Peyer's patches, and the lymphatic nodules of the Peyer's patches are present like that. This is muscularis mucosa, this thing, like this pale layer above the purple layer, that is muscularis mucosa, and then with the Peyer's patches, which are just nodules, purplish nodules and stuff like that. Then the Uworld point is that the integrity of the small intestinal mucosa depends on the complete and rapid neutralization of the hydrochloric acid and the gastric contents, because the small intestinal mucosa is going to perform very well in the alkaline environment, because the pancreatic enzymes are being secreted, the bile is present, all of that is functioning well in the alkaline environment. So the functionality of the small intestine requires the alkaline environment, and that must be attained as soon as possible. This is accomplished by the alkaline secretion of the two primary sources. Number one, The submucosal Brunner glands secrete the copious amount of the alkaline mucus into the duodenum. The glands are most numerous at the pylorus but may also be found intermittently at the ampulla of Vater. The duct of these glands pass through the muscularis mucosa and terminate in the mucosal crypts, the crypts of Leverkuchen. The epithelial cells of the pancreatic ductules and the ducts produce watery secretions containing high concentration of bicarbonate ions. So, number one source of bicarbonate is the Brunner gland, which are concentrated in the pylorus, and a second major source is the pancreatic ductules. The epithelial cells of the pancreatic ductules and the ducts produce watery secretions containing high concentrations of the bicarbonate ion. The strongly alkaline pancreatic secretions are then emptied into the duodenum at the ampulla. Okay, so both of these things are present in the duodenum because duodenum is the first area of the small intestine that is welcoming the chyme, the acidic chyme coming from the stomach. We'll keep it till here and then we'll continue with the alkaline secretion is stimulated by blah 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 in the next session. Until then, Allah Hafiz, fi amanillah, and